Nick.
Okay, we can start.
Okay. Okay, so I'm going to give the presentation on COVID-19 in otorhinolaryngology. My name is Wuhle. I'm a registrar in the Department of ENT at UCT. Then thank you for the opportunity, and welcome to Shazia and Darlene as well. Sorry, I'm going to share screen. Okay, Nick, can you allow me to share the screen?
Yeah, good to go.
Okay. All right. So I've got a few disclaimers for the talk. The first being that we know that there's a lot of information out on COVID-19, and a lot of this information has not been validated. All the evidence that I will present in this talk is level 4 and level 5 evidence, which is expert opinion and case reports, and there are no randomized controlled trials yet. So what we know so far is that the novel coronavirus is a global health emergency. Patient 0 was identified on the 17th of November in 2019 in Hubei province in China. And as of the 23rd of May at 10 p.m., there were 5,378,209 positive cases, and there were 342,835 deaths. And this figure has obviously increased since then. What else do we know is that ENTs are particularly at high risk of infection from their patients. And this is for two main reasons. The first is that COVID-19 may present with sinonasal symptoms, and because of the aerosol generating procedures that are part of our daily ENT practice. So Zara Patel and his colleagues from the University of Stanford collected a group of case reports from around the world from the first cases of COVID-19 that were encountered by some ENTs and the fate of the clinicians. So a few of these cases I'll talk about now. So one was a case in Wuhan in China. Is a patient who had mild flu-like symptoms, so underwent transsphenoidal pituitary surgery. This was quite early on in January. And at this time, like we said, the pandemic and its severity was not well established. It was reported that more than 14 of the members of the team then subsequently tested positive for COVID-19. In a separate case, a patient with a pituitary adenoma, known with a pituitary adenoma, developed a fever and a change in vision acutely. He was diagnosed with pituitary apoplexy and also a suspected viral pneumonia. The surgical team was aware of the potential risks of the infection, but because of the threatened vision, they went ahead with the case anyways, but had a full PPE. The surgeon and two of the nurses had N95 masks, and the anesthetist had what they termed a homemade positive pressure helmet. The operation was successful without incident, and then the surgical team was quarantined after surgery. Within 3 or 4 days, all of them developed fever and respiratory symptoms, except the anesthetist, but fortunately, they all recovered. In Iran, it was reported that 20 ENTs were hospitalized with COVID-19, and 20 more were in self-isolation at home. And then the most disturbing case was a young, healthy chief resident who had a short illness. He rapidly decompensated and died after it was found that he had acute myocarditis and cardiac arrest. So aerosol generating procedures are something that we do all the time in ENT, and an aerosol is by definition a small droplet that's less than 5 micrometers in size. And unlike a droplet that drops to the ground, aerosols linger in the air for 30 minutes or even longer, and this usually is by then the patient would have left the room. So tracheostomy tube insertion, suctioning tracheostomy tube, flexible and rigid endoscopy, IDL, drilling and irrigation during mastoidectomy are all aerosol generating procedures. Other AGPs are things like bag mask ventilation, non-invasive ventilations, which is CPAP and BiPAP, and then chest physio, which we frequently request, and nebulization. However, with nebulization, ENT UK guidelines states that it's not as high risk as the other AGPs because the aerosol is a non-patient source and does not contain patient-derived virus particles. So when the aerosol comes into contact with contaminated mucous membrane, it condenses and becomes a droplet. But staff obviously have to exercise good hand hygiene when removing the nebulizers. So the aim of this talk is to talk about how our ENT practice must modify during this pandemic, and to review some of the recommendations from other ENT societies. So American Head and Neck Society and the ENT Society in the UK, and then how can we adapt these to resource-limited Africa? So ENT activities revolve around three main scenarios, which is our daily ward work, the outpatients department, and the operating room. With regards to the daily ward work, not much has changed. It's just a few things. So we have decided that there should be fewer people on the ward round, and every member of the team must have a normal surgical mask on. So the nursing staff and whoever else joins the round, we must observe social distance, and we must avoid unnecessary patient contact, and obviously practice good hand hygiene in between patients. So with regards to the outpatient department protocol, there are a few assumptions that we need to make when dealing with outpatients. So the first is that we must assume that all patients are positive until proven otherwise. And in those who do test negative, up to 30% of them may be falsely negative. This was demonstrated by Yang in the paper shown below. He went on to describe that there were different factors that affect whether we get a positive yield or a negative yield from a specimen, and one of them was the type of specimen. So bronchoalveolar lavage had the highest yield, followed by sputum and then nasopharyngeal swabs. And then the time of collection of the specimen from the day of onset of symptoms also had a bearing. So the highest yield was obtained when the specimen was taken less than 2 weeks from the time of onset of symptoms. And the last assumption is all staff members are presumed positive even though they are asymptomatic. So who must we see in OPD? Well, the directive was we have to cancel all clinics and only see urgent cases. And these urgent cases include patients with upper airways obstruction, patients with suspected malignancy, epistaxis, and sepsis, so neck abscesses, quinsy, complicated sinusitis, mastoiditis, retropharyngeal abscesses. And then what happens to everyone else? Then we need to reschedule all visits, and if we have the facility, is to perform video consults. So our patients need to be informed, so screened and informed in advance, so the patients do not come and are sent away, which would obviously cause them to be frustrated. But we live in Africa, and not everyone is contactable on the telephone. Some people don't have telephones, some people don't have electricity to charge their phones, so we should expect walk-ins. And when the walk-ins come, then we need to have front desk screeners outside the clinic space that can make a decision on whether the patient needs to be seen, and obviously I can defer the decision to the doctors if need be. And then with regards to new patients, then we need to accept telephone referrals or video visits, preferably by a consultant, but this can be delegated to registrars as well. So ENT UK have given this diagram to show how doctors should conduct themselves during telephone consultations. And so just a few of the steps include introducing yourself, confirming the patient's identity, and ensuring confidentiality during the telephone call. If you're not able to reach the patient, then you can decide either to call again or to discharge the patient. And if the patient responds, do you have the patient's notes in front of you? And the rest of the diagram then gives different things that you can do in different scenarios. And in all cases, we need to clearly document that this is the COVID era and what you've decided to do and what you discussed with the patient. So once the patients arrive in the front, then there must be clearly labeled signs on the floor to remind the patients to maintain social distance. Our clerks need to be behind a clear screen, and they must have masks as well. There must be stickers on the floor reminding patients where to stand. In the actual waiting room, this is a picture of our waiting room. The chairs need to be marked in advance such that the patients are distanced when they sit, and make sure that alternate chairs are not allowed for sitting. There must be alcohol readily available for the patients to use, and if there's concern that these may be stolen, then they must be mounted onto the wall. There mustn't be any magazines or toys because this obviously can transfer infection. The OPD visit is also an opportunity to teach and educate our patients, so there must be posters on the walls reminding patients what the pandemic is about, reminding them to always put on their mask. Then the examination room must be decluttered. There mustn't be too many chairs, just one chair for the doctor and one for the patient. No unnecessary instruments, and there must be alcohol readily available and a sink with soap for the doctors and nurses to wash their hands. Then if we need to do a procedure, we must have a stainless steel trolley with an apron, an N95 mask, alcohol, gloves, and a waterproof apron. So an additional necessary requirement is negative pressure rooms. The CDC recommends that all AGPs need to be performed in a negative pressure room. And what that does is this allows 12 air changes per hour. The door should be self-closing and the windows must be permanently sealed. The concept of a negative pressure room is there's passive airflow into the room and then air is actively forced out. So there isn't any recirculation of air and the expelled air is passed through a filter. And this is connected to the hospital's heating, ventilation, and air conditioning system. So positive pressure room, on the other hand, is when air is actively forced into the room and then passively flows out. And this is used particularly when we have got immunocompromised patients who must be within a clean environment. A nice way to remember which room we use in this scenario is you use a positive pressure room, the contents of the room are clean and you want to drive out contaminated air. And then we use a negative pressure room if the contents of the room are contaminated and we want to suck the bad air out. The problem with the negative pressure room is the cost is prohibitive. So the cost is variable, anything from $1,000 US to $5,000 US to set up. And so if you cannot afford a negative pressure room, there are other cheaper alternatives. You can use a desk fan with an open door, or you can use an extractor fan that will extract the contaminated air out. And if you have both, then you can use both at the same time. And if you can't afford any of these, then you have the option of using natural ventilation. Your examination room must be in a place where you can open doors and open the windows and allow air to flow through the room. Right, so by the time the patients come to us, they must have been screened, and the screening tool must be easy. It's got 5 easy questions. Does the patient have a fever? Do they have a cough, a sore throat? Are they experiencing shortness of breath or a change in taste and smell? Then depending on that, then we risk stratify our patients. So those that have come in are unknown, and if they are symptomatic, then we have designated a PUI, which is a patient under investigation. And so these patients then need to be tested. And then those who do not have symptoms are asymptomatic. And then depending on the results of the test, they can either be negative or positive. And with the positive patients, if they're well enough to go home to self-isolate, then that's what happens. But if the patient is not well, then they're referred to the COVID team for active management. Note that there are no patients where we relax any of the rules. We have to observe caution with all patients, even though they have a negative result. So with regards to the PPE, this is an illustration of what we are expected to have. So the doctors must have an N95 mask on, they must have goggles, they must have the visor and a waterproof apron. We must avoid unnecessary interaction with patients, and like we said, there shouldn't be any relatives actually during the consultation. And then if we are performing biopsy or any other AGP, then you can also add an apron on top. Another innovative thing that you can do is to strap a plastic at the lower end of the visor, and this then protects your neck from aerosols as well. So we all need to be familiar with the process of donning and doffing, and a hospital management needs to organize training sessions so all staff are aware of the protocol. So the general rules for examination are we need to avoid flexible scopes in all patients unless we have a negative result. And even when we have a negative result, we still need full PPE. In the event where surgical intervention is required, like a biopsy or a tracheostomy, then it's more suitable to do this in theater if you have a theater time. We need to limit transnasal and transoral procedures, and we need to avoid instrumentation in head and neck cavities and the mucosa where possible. We need to avoid topical medications and use plagiaulates instead of the spray where possible. And we must disinfect all medical and non-medical surfaces, so our cell phones, pens, and all other stationery that we have. And if we can, we need to vacate the room for an hour before the next patient comes in. Okay, so this is a video illustrating how we are conducting our flexible scopes. So the patient lies supine and a plastic bag is draped so behind the patient's ears. And then if the patient coughs, so anything that goes into the bag, and 2 slits are made in front of the bag where the scope goes in. And so everything then goes into the bag, and once we are done with the patient, then we discard that and set up for the next patient. So with regards to our theater protocol, we only operate on emergency cases and urgent cases, and we need to reschedule all electives and non-urgent admissions. Now the consultant needs to be heavily involved with which patients are taken to theater. We need to avoid having too many people in theater, so there can't be too many spectators, and this will impede on the registrar's cutting time. And then again, we need to operate in negative pressure rooms. So this list is not exhaustive, but some of the procedures that we definitely can postpone are the cyst-trunk procedure, tympanoplasty, tonsillectomy for recurrent tonsillitis and mild OSA, and grommet insertion. And then there are procedures that we must not postpone, which is your head and neck cancer cases, complicated sinusitis, epistaxis that's refractory to non-surgical management, adenotonsillectomy for severe OSA, and all the others listed. And then there are some that are subject to discussion. So FAES, cholesteatoma surgery, benign laryngeal surgery, angiofibromas, and CSF leak. So in theater for a COVID unknown or COVID negative patient, the expectation is that, so we wear our regular theater attire, and that's the apron, the shoe covers, and a head cover. Then on top of that, then we put on the N95 and the visor, and for surgeries requiring loops, then we can put the loops underneath the visor. But all of this PPE is not something that we are used to, and there are problems that we can anticipate. So the goggles missed frequently. All the equipment may make you feel claustrophobic. You can't use the headlamp when you have the visor on. And then the tight-fitting visor and goggles around your head are actually painful. And then we cannot communicate as we used to because everyone's voice is muffled. And we can't directly look into the scope. And so now we have to use this camera and the stack in all those cases. If the patient is a known COVID positive patient, then we need to activate the COVID protocol, in which case the case needs to be done in a dedicated COVID theater with negative pressure. The indication for the procedure must be clear and the benefit must outweigh the risk of exposing everybody. The surgery needs to be performed by the most skilled person available and also intubated by the most skilled person available. And then with regards to surgical techniques, we are limited because we need to limit the use of the drill, microdebriders, monopolar cautery, lasers, and core ablators. In an ideal setting, you can use the powered air purifying respirator and the hazmat suit, but obviously, like I said, these are very expensive. The respirator is costing anything from $1,500 US and upwards, and the hazmat suit costing anything up to from $45 US and more. In our setting, we have a shortage of PPE, and so we need to consider reusing our masks and the rest of our PPE. So the study was carried out by the NIH, and what they were looking at was they were trying to see whether it's feasible to recycle your N95. And what they did was they looked at 4 methods, which is the use of 70% alcohol, hydrogen peroxide spray, UV light, and dry heat. What they found was the time taken to adequately disinfect differed. So with the alcohol, it was variable, but the most effective, the hydrogen peroxide spray, it took 10 minutes to disinfect, but the UV light and the dry heat took up to an hour to disinfect. And then the integrity of the mask obviously declined. And again, the hydrogen peroxide spray was superior this time with the UV light. So you could treat the mask up to 3 times and it still fitted well. But with the dry heat, you can treat the mask twice, and with the alcohol, just after 1 treatment, users found that it was no longer fitting as well. So a few honorable mentions. So we'll talk about the tracheostomy in a positive patient for prolonged intubation. Now we know that there's an established role for tracheostomy in ventilated patients. There's reduced work of breathing, reduced sedation requirements, and this reduces the overall length of their stay in ICU. But as we've said already, this is a very high-risk procedure for the surgeon, the anesthetist, the scrub nurse, everyone involved, the porter and the ICU staff. We are directly accessing the airway. The patient will require mechanical ventilation and the subsequent tracheostomy care. So open tracheostomy is safer than awake tracheostomy or percutaneous cricothyroidotomy because we can't control airflow cessation in the latter 2 scenarios. So the American Head and Neck Society recommends the following. So we need to avoid tracheostomy in COVID positive patients or suspected patients in those periods when they have respiratory instability or they have heightened ventilator dependency. And some of the things we can use are like the ventilator settings. So they must be on low ventilator settings, which is an FiO2 or 40 or 50. They must have a PEEP, be managing on a PEEP of less than 12. The patient must not be on ionotropes. The patient must not have any bleeding disorder and must be of general good health. And also they must pass the apnea test. A tracheostomy should not be considered sooner than 21 days from intubation. And where possible, the patient must have 2 negative PCR tests 48 hours apart. We must have full airborne precautions with appropriate donning and doffing. And then the most skilled anesthetist must be in the room. And then the most skilled surgeon available on that day must also be in the room with 1 assistant. Another consideration is to organize a permanent tracheostomy team, and in that way, then they get more efficient with each case. Intraoperatively, we need to limit the use of suction and electric cautery, and we need to establish complete paralysis to minimize aerosol dispersal. We must maintain adequate pre-oxygenation for 5 minutes prior to making the window on the trachea, and they need to hold off ventilation or bagging the patient once we've made the flap. Then after tracheostomy placement, the patient must be connected to a ventilator with a viral filter. Post-op, the tracheostomy change must be delayed until the patient is no longer testing positive. Then the ICU staff must be discouraged from disconnecting the patient from the ventilator unnecessarily. And if they have to, then they can clamp the tubing distal to the viral filter before they do this. And then we must not deflate the cuff until the patient is ready to be weaned off the ventilator. The second honorable mention is a patient that, a pediatric patient that presents with acute stridor. In this instance, there's no time for a COVID test, and so we assume the patient is COVID positive and use a dedicated COVID theater. Where definitive management is possible, then we need to aim for that. So your laryngeal papillomas, foreign body aspiration, retropharyngeal abscess. And then we need to intubate for the surgery to minimize the aerosols. Then we need to aim to intubate where definitive surgery isn't possible. And this means we need to discuss with ICU prior to taking the patient to theater to determine the bed status in ICU. We have to avoid nasal intubation, and we have to use a cuffed ETT where cuff pressure can be monitored. And so we've also been innovative, and we have a few techniques that we use to reduce aerosol dispersal. So one of the options is you can drape the patient with a clear plastic prior to intubation, and with the patient having a mask. So in this picture, we see how we've draped our mask with, so there's a clear plastic just over the mask, and we can hold that comfortably over the patient's mouth and nose. In this picture, we see how there's a clear drape over the patient while performing video laryngoscopy. And we can do the same during direct laryngotracheal bronchoscopy, but in this instance, we need to turn off the overhead lights so there isn't a reflection. And this picture shows a clear drape over the head and neck region during a tracheostomy. And then this is just showing an ETT with a filter attached to it. Okay. And then the last honorable mention is, how do you manage a patient with new onset anosmia during this COVID era? You can broadly divide your patients into three. So is this a patient with isolated anosmia? Is it a patient with isolated anosmia with neurological symptoms? Or is it a patient with, it's a patient with anosmia with neurological symptoms or anosmia with nasal symptoms? If the patient has anosmia only without any other symptoms, if they are COVID positive and it's less than 3 months, then they can be managed by the GP. If they're presenting with anosmia for more than 3 months, then they can have an ENT referral, and in this instance, an MRI scan is not recommended. In a COVID negative patient or COVID unknown, the ideal is to proceed with a COVID test first and then perform nasal endoscopy. An MRI is indicated if endoscopy is normal. In anosmia associated with nasal symptoms, it's the same as I've just discussed. So first we proceed with a COVID test and then a nasal endoscopy. Then we need to be suspicious in a unilateral nasal mass, where we will then need to organize imaging and a biopsy to exclude malignancy. In a patient with anosmia and neurological symptoms, if they're presenting to us with more than 6 weeks of symptoms, then an MRI scan is indicated regardless of the COVID status. With regards to management, like the medical therapies, so This is from ENT UK as well. They looked at 4 modalities of treatment and whether they were recommended or not. So olfactory training, intranasal steroids, and nasal douches are recommended safely COVID negative or positive. But of note is oral steroids are not recommended in COVID positive patients with active disease because this will exacerbate their illness. So in conclusion, we as the ENT community have to help the rest of the world in preventing COVID-related deaths, but also more importantly to us is we need to prevent non-COVID ENT-related deaths during the pandemic. We have to continue thinking of new ways in which we can practice ENT safely, and this will collectively help everybody. We must not participate in mass hysteria. Some of the resources I used for this talk are the open access textbook, Prof. Fagan's, and there is a special link added for COVID-19. Also the ENT Africa guidelines, and ENT UK. And these are some of my references. Thank you.
Hi, I'm Darlene Libbe from Cape Town, UCT. Buchle, it was a fantastic presentation. There's a couple of things that that I would like to comment on, and one, the biggest risk during your clinical examination of a patient is actually when the patient sneezes or coughs. And this is why it's so important for ENT surgeons to always wear an N95 mask when they examine any patient, you know, even those that are presumed COVID negative. Because during endoscopy, you can never predict when a patient might sneeze or cough, and that's where your aerosolization happens during that procedure. And that's also why we use that bag, the plastic bag over the patient to help with that in case there is an accidental cough or a sneeze. So it's very important for the patient to wear a normal mask, and you to just lower the normal mask, you know, when you're going to do your endoscopy. And then there's also an article by Professor Benjamin Bly from Harvard on showing how to examine a patient safely. And what they do is they let the patient wear an N95 mask, and they take a little a piece of glove, and they stick in the middle of your surgical mask. They have a piece of the glove, and they make a little hole, and that's where the endoscope goes through. So the patient during the endoscopy actually has a mask on. So that's another trick that you can use. But I would always say the surgeon, N95 and also goggles. And then when it comes to, with regards to the negative pressure, obviously that's ideal. And in Africa, we don't always have access to that. Even in in first world countries, they haven't got this as a standard, and it might become a standard soon. But some other tricks, as you say, is to do what we're doing in our clinic at the moment is we're actually doing these endoscopies outside, or, you know, if there is not a negative pressure area. And this is the same area where we do the testing for the patients. Another trick, if you don't have an extractor fan, is you could, if you have got air conditioning, is you can put the air conditioning on high and open all the windows, and that gives you like a positive pressure where you kind of wash out the dirty air between patients. And then during endoscopic sinus surgery, what I would like to comment on with regards to the PPE, things that I found. So I'm a shorter surgeon, and standing doing endoscopic sinus surgery, I've really found it very difficult to operate with a visor, because as you hold the camera, your visor keeps on knocking against your endoscope. So you're actually contaminating your camera, and it becomes quite uncomfortable. So I've actually stopped operating with a visor, but I would wear an N95 mask or a respirator, and then sealing goggles, and the big goggles are better. And that's quite comfortable to operate on for the whole procedure. And then with regards to tracheostomies, maybe Nick would like to comment a little bit more on this. But so we've done a couple of COVID positive tracheostomies, and recent research has shown that even if you have still got a positive COVID test, it doesn't necessarily mean that that patient is still shedding live virus. It might, the PCR might stay positive for a couple of weeks, but the patient might not really be infective anymore. So that's, and I think the day, there's day 12 more or less, but Nick can just comment on that. So you want to wait until at least 14 weeks, I would say, before you even consider a tracheostomy, and only if the patient is doing well, because we know from the studies in China and Italy that the death rate for ventilated patients is very, very high. And then also to remember with regards to your tracheostomies, that all of these patients, or most of them, are now being anticoagulated because of the risk of thromboembolism. So these tracheostomies are a little bit more difficult because a lot of these patients are obese. It's morbid obesity, or BMI over 40 is one of the big high risk factors for getting severe COVID disease. So you're already dealing with a patient that is medically often unstable, with diabetes, hypertension, obese with a fat neck, and now they're anticoagulated. So it's important to do it in the tracheostomy in the correct environment and under controlled circumstances. And although there's some people saying that you shouldn't use coagulation, we do use a coagulation. You just need to have your proper PPE on, and you do it under plastic if you can. So you can also, once you start incising the trachea, put plastic over the patient and do everything under that plastic cover. So I think that's all that I have to say. I'm not sure if there's anything else from your
Arlene,
side.
I think another question that came up was the recommendation of staff and whether it's feasible for us to go off, like take days off after this exposure.
Yes, I think, thanks, Buckley, that I think is definitely not indicated. I mean, the only time that you have to isolate is if you have been exposed without wearing PPE. So in these circumstances, it's always very controlled. The doctor has PPE on, your anesthetic staff are all prepared. The patient is paralyzed, as you suggested. Your nursing staff wears a proper PPE. So the only time that you would have to be isolated is if there's an accident during the surgery and your mask comes off, for instance, and the patient is coughing for some reason. Then I would say you probably have had an exposure, and that would mean that you need to be off. But I mean, we test patients on a daily basis, so we almost have some days 28% patients positive out of a group of 160. So I mean, that means you're in direct exposure to that patient. But because you're wearing PPE, we go along with our day as per normal. We go home, we see other patients during the clinic, so no reason to isolate.
Thanks, Prof. Lubbe. Any closing comments, Shazia?
Yeah, thanks. I'll be very brief. I think what I do want to say, and this is something that's come to the fore, is this is a real problem. It's not actually going away. And the earlier we change our practice, the better. Because from now onward, our practice will never be the same. We have to adjust to give ourselves enough opportunity to minimize risk of contracting any infectious disease like COVID and TB. For ourselves, our own healthcare workers, as well as for the patients. So anything that we put into place for our clinics must be a definitive plan for that, or else we risk getting infected. What we do know is that, and this has been a phrase coined for COVID, is it's an epistemic disease, meaning it's evolving and we still don't know enough about it. And I think this is what's affecting us moving forward. But what we can say is that there are some things we can be really conscientious about. And one thing that Darlene has mentioned is never take your mask off and never be less than 1.5 meters from someone without a mask, and try and spend at least less than 15 minutes close to someone else, because you assume everybody is positive. For children specifically, the risk to the healthcare worker is higher, because not only do you have one patient, but every patient comes with a carer. So we must ensure that the child wears a mask in addition to the parent. When we are examining them, we must make sure that there must be only one person in the room, and all of the patients who are coming into the clinic must be within a fair distance from each other. And even if patients are being admitted, try and avoid more than one carer, and if we have the resources, to test those people. I think those are quite important to bear in mind, because people are asymptomatic carriers and they come into our space. Thanks, Buhle. It was a really nice talk.
Yeah, thanks.